Hello, everyone. It's indeed a great pleasure to be part of KSOS NABH session. My topic today is NABH Eye Care Standards and the first chapter. So let me start my screen. As you all know, NABH Eye Care Standards have been one of the master strokes with reference to accreditation in our country. It is the first specialty eye care standards. And the first chapter of this eye care standard is again access, assessment, and continuity of care. As you all know, NABH standards have 10 chapters. Of that, the first 5 chapters are patient-centered standard, and the first chapter is access, assessment, and continuity of care, represented by the acronym AAC. It has 7 standards and 32 objective elements in eye care standards. The section 2 is the management-centered standards. Again, has 5 standards, and totally we have 58 standards and 305 objective elements. So let us see how we can learn about access, assessment, and continuity of care, and how we can implement these standards in our practice. Before going to the standards and objective elements, it's important to understand the intent of chapter. If you go through the NABH standards booklet, on the first page, you will see the intent of each chapter. For assessment and continuity of care, these are the intent. The first intent is appropriately matching patients with ECO's resources, conducting appropriate assessment in OPD, IPD, and emergency department, performing lab and imaging investigation in a safe manner, providing standardized discharge summary, and providing multidisciplinary patient care. Let's go into the depth of this chapter and see how we can implement these standards. So most of the eye care organizations have been implementing NABH standards, particularly this chapter very easily, because most of these are already in place. The first objective element is healthcare services being provided or clearly defined. So how do you define the services you provide? So this is a question of most of the organization going for entry level or the first assessment of the eye care standards. So most of us will be providing comprehensive eye care services, cataract services, glaucoma services, and some of us will be providing refractive services and retina services. And these are specialty services. So if you have the infrastructure in place to provide these services, and also the manpower to provide these services, you can always put this under your scope of services. Some of us will be providing 24/7 emergency and trauma services. So if you are providing that, you can include that in your scope of services. There will be also auxiliary services like optical, contact lens services, pharmacy, MRD services. Some of us may not have this pharmacy or insurance support. So in that case, you can always mention that not in scope at present. So for example, this is a scope of services for our hospital. So we don't have ocular oncology services or rehabilitation services, and that is displayed in the scope of services. The second objective element is each defined services. This is where you have to write the scope of services clearly, because to have that particular scope of service, you need to have appropriate diagnostic and treatment facilities with suitably qualified personnel who can provide outpatient, inpatient, and emergency care. So how do we decide this? Suitably qualified means, for example, retina services, you need to have a retina trained as well as a doctor with retina fellowship. A nursing staff, if you are going to have a theater or critical care facility, you need to have nursing staff trained in BSc nursing or diploma nursing. So these are essential qualifications for a particular cadre like doctor or nursing. You also need to have outpatient as well as inpatient facility to provide, for example, retina care or pediatric ophthalmology care, where you need to have anesthesia services as well as recovery services. So you need to have appropriate infrastructure for the scope of services. And these services, what you have defined and accepted as scope of services, have to be prominently displayed. So this may be in the form of display of services along with ancillary services as well as outsourced services. And you also have to orient your staff to these services. So this is our display of services. You can see that it is in bilingual, pictorial signage, and both services provided and not provided are also displayed. It's always ideal to have bilingual language representing the region, commonly language commonly spoken in that particular region. The display should be updated with the new services and should have semi-permanent or permanent boards and not temporary flex boards. How to implement this? So you have to list all your services, both clinical, diagnostic, and support services, and display them in patient care areas, in the entrances, registration, waiting areas, and emergency department. And you have to give training to your staff, particularly reception staff and the OPD staff, about the list as well as the display of services. And the list and training must be up to date. The second standard is about registering and admitting patients. You need to have a format for OPD, and you need to have a UHID, Universal Health Identification document, and you have to document the process. And for emergency patients, you should have a system to provide first aid and stabilize the patient before transferring or treating as inpatients. Initial assessment in eye care is usually done by the vision and ophthalmic assessment. You need to train them to ask for basic complaints and salient examination findings. And for daycare, you can have abridged documentation. And these are the best practices for registering patient in your eye care facility. Link the number to UHID to provide continuity of care every time the patient comes. And for medical legal cases, you need to have a system in place. And if you are treating foreign nationals, you need to register them after due verification of their document. So in the event of an admission, the organization must be equipped to provide the required service. Only then you can admit those patients. So you should have the infrastructure as well as trained manpower. AAC 2B addresses the mechanism of transfer or referral of patients who do not match the organizational services or organizational resources. So you should have a list of referring facilities. It may be ophthalmic institution or a multi-specialty hospital. So you should have a MOU with the general hospital as well as all the outsourced services like lab, ambulance services. And if you don't have ambulance of your own, you need to have a tie-up with the ambulance services agency, and you should have a MOU. The organization has a documented registration, admission, and transfer process. So you can accept only if you can provide the required service, particularly polytrauma patients or pediatric patients requiring general anesthesia and post-anesthesia care. So some of the hospitals may not have the required facility. In that case, you have to refer them to the organizations where they have the required facilities. And you also need to have a system where during non-availability of blood, how do you transfer the patients? AAC 2E, you need to prioritize the healthcare services as per the need of the patient. So for example, you have a conjunctivitis patients, or even during this COVID season, we've been seeing conjunctivitis patients. In that case, you need to prioritize these patients so that they don't spread the infection to others. And if you have a casualty or emergency OP in place, so you can do a triage and see that these patients are sent off early after seeing them and treating them. And the staff should be aware of these processes. They should be trained about the triage for eye care diseases. So how to conduct the initial assessment? AAC 3 is focused on how the organization should do an initial assessment. Most of us are treating the patient as a daycare patients. You need to have uh, conduct initial assessment with history. An emergency patient, as I told already, you need to have a triage system. And if it's a daycare patient, you can have a bridge assessment. And the initial assessment should also be done within 24 hours. And that should include general nursing, general parameters, as well as nursing assessment. So you should document vital parameters, the examination findings like a general examination, particularly respiratory rate and CES. And if there are medication related to the general treatment, you need to mention that in the case record. So how to implement this? You need to have a standardized format for initial assessment. And depending on the department, like retina, cornea, or refractive services, or even pediatric ophthalmology services, or oculoplasty, you need to modify the parameters. So you should have designated doctors, both in the OP and IPD, as well as optometrists trained in that particular specialty, and also nursing people who can do nursing assessment as well as dietary assessment. And if you have pediatric ophthalmology, the doctors or nurses should be tuned to the screening of nutritional needs. And you also need to define the time frame by which initial assessment should be done. Ideally, in a OPD setup, 1 to 1.5 hours, depending on the need for dilatation. And in the IPD setup, at least 1 hour, you have to do the initial assessment. The AAC 3 focus on the initial assessment and having a format. So this is a format we use, the EMR format. The vision and ophthalmic assessment is done by the ophthalmic assistants or optometrists, and then later on, it is validated by the doctors. So initial assessment shall be same in the eye care on the whole, but in case of retina department, it should include the fundus, indirect ophthalmoscopy, as well as various imaging parameters. And for all IP patients, you need to do a general assessment. Apart from the initial assessment, when they come for regular checkup or for admission, or they have to undergo a regular reassessment, and this particular standard focus on this aspect. They have to be reassessed at appropriate intervals to know that the disease is progressing or responding to treatment. So how do we implement this? If the patient is coming for a review, they should be assessed by the optometrist. And if they are seeking expert advice, like a specialist, cornea specialist, or retina specialist, they should be continuously assessed by the primary doctor, as well as if you are referring them, you need to transfer the patient for the to the referral doctor. So how to implement this transfer care, and then you need to have a defined designated time frame for the consultant to see the patient, as well as get the details from that particular consultant. AAC 5 focus on laboratory services, and the scope of laboratory services should be defined as per the scope of the services provided by the eye care organization. You should have certain procedures, standard operating procedures, which will guide the collection, identification, handling of specimens, as well as processing and disposal. Most of the eye care organizations have outsourced this particular area to another lab, and in that case, you should take care of the identification and processing, transfer of these specimens. And the result, you should ensure that it is available within the defined time frame. And if there are critical results, those results are intimated to the organization. So the services offered should complement the clinical services. It can be outsourced, and if you have outsourced, and for essential services, if you have facility for 24/7, and these outsource activity have to be there for 24/7, and it should be available within premises for emergency. Some of the tests like blood sugar should be available within the premises, even if you have the outsourced services. And you also need to define the turnaround time and waiting time for the results, and the critical values should be reported to the doctor in charge. Then AAC 5, the next 3 objective elements focus on having a trained personnel perform, supervise, and interpret the investigation. And if you have outsourced lab, see to that they have the NABH certification, or they have this NQA system where their reports are validated by a accredited laboratory. And lab tests which are not available in organization, you can certainly outsource, but see to that the safety measures are in place. If you are having phlebotomy services, ensure that your staff wear PPE and handle the microbiological samples properly. Ensure availability of MSDS, minimum material safety data sheets, and also having hazardous materials fill kit. And during COVID season, if you are handling RT-PCR or similar tests, ensure that you have appropriate lab facilities and your people wear N95 mask or more than N95 mask. And these are the points to remember when you are outsourcing your activities to a laboratory, a referral laboratory. See to that the test methodology is validated or approved, and TAT is agreeable with the clinicians, the turnaround time. And you also need to visit those outsourced lab and see where the equipment and environment are safe and available, and sample pickup and reporting services are prompt. And you can also ensure cost effectiveness for the benefit of the patients. So what should be listed in the Apex manual about the lab? If you're having your in-house or outsourced laboratory, you have to include these parameters. What are the tests that are done in-house and what are the tests that are outsourced? And ensure that the name of the outsourced lab is part of your Apex manual, and what instruction you are given to the staff for proper collection and handling of sample. Lab services should also be displayed in prominent places in the hospital. This particular standard, AAC 6, focuses on diagnostic and imaging services which are provided as per the scope of services of eye care organizations. Most of us have specialty services in our hospitals. As per the scope of the services, you need to have the diagnostic and imaging facilities. For example, if you're having a retina specialty as the scope of services, you definitely need to have a fundus imaging device as well as the manpower to take the fundus imaging and to report that imaging within a time frame. So if you don't have these facilities like OCT or FFA, you can certainly outsource to the other healthcare organization based on their quality assurance system. So whatever services you should offer, particularly imaging services, it should complement clinical services. It should be available as per the time of your services, and this should be displayed at prominent places. Ensure again, here ensure if you are outsourcing, turnaround time, the waiting time for the imaging, the critical results. For example, if you are dealing with the endophthalmitis case, B-scan imaging is very important, and you should ensure that the report reaches you on time. So documentation is very important with reference to imaging, and particularly if you are doing an invasive procedure, you need to have a consent process in place. And if you are getting critical results, those things have to be documented about the time frame as well as the report. And if you are using a contrast, like for example in FFA, if you encounter any adverse reaction, that should be documented. And you have to list all the outsourcing services, have an MOU with the outsourced services, and periodically review these imaging services and evaluate the performance of the referral center. The last standard in eye care standard AAC 1, AAC is having a defined discharge process. So you'll be admitting patients, including medico-legal cases, and also some of the patient might leave against medical advice. So you should be giving discharge summary for all the patients leaving the organization. Discharge summary should contain the reasons for admission, investigations, as well as the other details. And how you can implement this is the doctor can order the discharge after seeing the patient, medicine returns and clearances, and then you can issue the discharge summary. It should be in a standard template, particularly if you are working with insurance companies. They prefer standard template. It should be brief and contain all the important information signed and by a treating doctor or a member of the treating team, and should be given to all patients, and hospital should monitor the discharge time for quality improvement. And the patient or the family should acknowledge the receipt of discharge summary. Ensure that discharge summary have follow-up advice. It should not have unfamiliar abbreviation because patient may not be doing that. And this discharge summary should be verbally explained to the patient, particularly the details for urgent care, when they should come for the urgent care, what is an emergency, particularly cataract patient having sudden loss of vision or severe eye pain, they should report to the hospital immediately. So this should be told to the patient as well as given in the language the patient or relatives understand. So what should a discharge summary cover? This is the overview of the various parameters required for a discharge summary for all patients, including LAMA, discharge summary, and all investigation reports should be handed over to the patient. To sum up, AAC is the first chapter of NABH Eye Care Standards. These are the overview of the 7 standards and objective elements. These are the important aspects: signage and display, and documentation, initial assessment, reassessment, the laboratory services, imaging services, and discharge process. So this is the beginning. The woods are lovely, dark and deep. So, but we have another 9 chapters to go and miles to go before we attain accreditation. Thank you very much for your kind attention.